Our hearts are responsible for sending blood throughout our body and bringing it back to our lungs in a constant exchange of oxygenated and deoxygenated blood. Here at Osmosis, we also think your hearts are responsible for starting with the heart and showing us love every time you watch one of our videos. But remember, the heart itself also needs its own blood supply, called the coronary circulation, which it gets from the right and left coronary arteries. The coronary arteries are embedded in fat and course across the surface of the heart just deep to the epicardium. Let's begin with the right coronary artery, or RCA, which has its origin in the right aortic sinus and passes to the right side of the pulmonary trunk. Close to its origin, the RCA gives a sinoatrial nodal branch, which supplies the sinoatrial node. The RCA then descends in the coronary sulcus. Along the way, it gives off the right marginal branch, which gets close to the apex but doesn't reach it and supplies the right border of the heart. After giving this branch, the RCA turns to the left and continues its journey in the coronary sulcus posteriorly. Here, the RCA gives yet another branch, the atrioventricular nodal branch, which supplies the AV node. The RCA usually gives the posterior interventricular branch, which descends in the posterior interventricular groove. This branch supplies areas of both ventricles and sends perforating interventricular septal branches into the IV septum. Finally, the terminal branch of the RCA continues for a short distance in the coronary sulcus. The left coronary artery, or LCA, originates from the left aortic sinus and passes between the left auricle and the left side of the pulmonary trunk and gets in the coronary sulcus. At the superior end of the anterior interventricular, or IV, groove, the LCA divides into two branches: the anterior interventricular, or IV branch, sometimes called the left anterior descending, or LAD, and the circumflex branch. The anterior IV branch passes through the anterior IV groove to the apex, where it turns around the inferior border of the heart and typically anastomoses with the posterior IV branch of the RCA. The anterior IV branch supplies parts of both ventricles and the anterior 2/3 of the interventricular septum through septal branches. In many people, this branch gives rise to the lateral branch or diagonal artery, which descends to the anterior surface of the heart. Now, the circumflex artery runs in the coronary sulcus around the left border of the heart towards the posterior surface of the heart. On its way, it gives the left marginal branch, which also has many tiny branches that supply the left ventricle. Most commonly, the circumflex branch of the LCA terminates in the coronary sulcus on the posterior aspect of the heart prior to the crux of the heart. Okay. To wrap things up, RCA supplies the diaphragmatic surface of the heart, the right atrium, most of the right ventricle, the diaphragmatic part of the left ventricle, and it usually also supplies the posterior third of the interventricular septum, the sinoatrial node, and the AV node. The LCA typically supplies the left atrium, most of the left ventricle, part of the right ventricle, the anterior 2/3 of the IVS, including the AV bundle, through perforating IV septal branches, and the sinoatrial node in some people. And the reason for all the sums and usuallys is because there is something called dominance of the coronary arterial system, which refers to whether the right or left coronary artery gives off the posterior interventricular branch. In 67 to 85% of people, the right coronary artery gives rise to the posterior interventricular branch, so the most common distribution is the right dominant pattern. In this case, the RCA and LCA are each in charge of about 50% of the heart supply. In about 8 to 15% of cases, LCA is dominant and the posterior IV branch comes from the circumflex artery. In 7 to 18% of people, there is codominance, and both RCA and LCA give rise to branches that run in or near the posterior IV groove. And if you thought that all on its own made each of us special, think that some people might have just one coronary artery. In others, the circumflex artery might have its origin in the right aortic sinus. 4% of people have an accessory coronary artery. Finally, the RCA gives the sinoatrial nodal branch 60% of the time, and the AV branch 80% of the time, while LCA is responsible for the other scenarios. That's quite some variation. Even though the branches of the coronary arteries are considered to be functional end arteries, the heart does have the potential to develop collateral circulation. This typically occurs between the termination of the right and left coronary arteries in the coronary sulcus between the IV branches near the apex in 10% of normal hearts and can potentially develop for all hearts. Alright, now where there are arteries, there are veins. So there are heart veins that empty into the coronary sinus, which drains into the right atrium, and some small veins that empty directly into the right atrium. On a posterior view, you can see the main vein of the heart is the coronary sinus, which is a wide vein that runs from left to right in the posterior part of the coronary sulcus. On its left side, on the anterior surface, it receives the great cardiac vein, which is the main tributary of the coronary sinus and drains the areas supplied by the LCA. The great cardiac vein begins as the anterior interventricular vein near the apex of the heart, which accompanies the anterior IV branch of the LCA towards the coronary sulcus. Then it turns left, and this second part of the great cardiac vein runs around the left side of the heart with the circumflex branch of LCA to reach the coronary sinus. Then there's the oblique vein of the left atrium, also called the vein of Marshall, sadly not named after the lovable character from How I Met Your Mother, which is a small vein that descends over the posterior wall of the left atrium and merges with the great cardiac vein to form the coronary sinus. Let's switch gears and look at some more veins on a posterior view of the heart. Here, the coronary sinus receives the middle cardiac vein, which accompanies the posterior interventricular branch, and the small cardiac vein, which accompanies the right marginal artery of RCA. These two veins drain most of the areas supplied by RCA. The left posterior ventricular vein and the left marginal vein also open in the coronary sinus. Some other veins begin over the anterior surface of the right ventricle, cross over the coronary sulcus, and end directly in the right atrium, or sometimes enter the small cardiac vein. Alright, as a quick recap, the heart receives arterial blood supply from the right and left coronary arteries and their branches, and venous blood is drained by the middle cardiac vein, the left marginal vein, as well as the left posterior ventricular vein, part of the small cardiac vein, and the oblique vein of the left atrium. Dominance of the heart refers to whether the right or left coronary artery gives off the posterior interventricular branch, where 67 to 85% of people are right coronary artery dominant. On an anterior view, you can see some of the vessels that supply the heart, such as the RCA and its right marginal branch, a bit of the LCA and the whole anterior interventricular branch of LCA, as well as part of the circumflex artery. You can also see the small cardiac vein following the right marginal branch, the anterior part of the great cardiac vein following the anterior interventricular branch, and finally a small part of the middle cardiac vein. On a posterior view, you can see the left posterior ventricular vein, the posterior interventricular artery, the middle cardiac vein, and the coronary sinus, which collect most of the venous drainage.
The heart is a muscular organ just slightly bigger than a person's loosely clenched fist. It's located in the thorax, more specifically between the two lungs, in a space called the mediastinum. The heart is covered by a tough membrane called the pericardium that separates the heart from the other structures in the mediastinum. This position allows the heart to do its job, which is to pump oxygen-rich blood to the entire body and to send poorly oxygenated blood to the lungs, where gas exchange can take place. The heart is made up of 4 chambers, and as a whole can be functionally divided into the right heart, made up of the right atrium and the right ventricle, and a left heart, made up of the left atrium and left ventricle. Both atria have pouch-like protrusions called auricles, which can increase the capacity when needed. Okay, now, poorly oxygenated blood from our bodies and other tissues enters the right atrium through the superior vena cava and inferior vena cava. From there, blood passes into the right ventricle, which pumps into the pulmonary trunk on a voyage towards the lungs and is considered part of the pulmonary circulation. On the other hand, after gas exchange takes place in the lungs, Oxygenated blood returns from the lungs through 4 pulmonary veins, which drain into the left atrium. Then, oxygenated blood goes in the left ventricle, and from there it's pumped into the aorta so that it reaches the whole body and is considered part of the systemic circulation. So looking at it in 3 dimensions, the heart looks like an upside-down, tipped-over pyramid with 4 sides, a base that's mostly posterior, and an apex or tip that points anteriorly and slightly to the left. On an anterior or posterior view in 2 dimensions, the heart is shaped like a trapezoid, so it has a superior and inferior, as well as a right and left border. It's important to understand what comprises the borders of the heart, because the heart is rotated to the left on its longitudinal axis within the mediastinum, so the apex is directed more posterolaterally. The superior border is formed by the right and left atria. Along the superior border, from right to left, there's the superior vena cava, which enters the right atrium. Then there's the ascending aorta, which emerges from the left ventricle and then curves posteriorly to form an arch, called the aortic arch. Finally, there's the pulmonary trunk and its 2 branches, the right and left pulmonary artery, with the right pulmonary artery going under the aortic arch. The inferior border is almost horizontal, and is made up mainly by the right ventricle and part of the left ventricle. The right border is made up by the right atrium, and it's between the superior and inferior vena cava. And finally, the left border is mainly made up by the left ventricle and part of the left auricle. Now pay a bit of attention here, because the end of the inferior border, along with the lower part of the left border, make up the apex of the heart, which represents the tip of the left ventricle. Some of these features can also be identified on a posterior-anterior chest X-ray. The heart silhouette is between the lungs, and the right border made up by the right atrium, as well as the left border made up by the left ventricle and part of the left auricle, can be clearly seen. Above the left auricle, we can identify the pulmonary artery and the aortic arch. The superior and inferior borders of the heart aren't as easy to see as the right and left borders. Now, let's identify the structures in an anterior and posterior view. On an anterior view, we can identify several structures, starting with the 4 chambers and ending with the great vessels. From right to left, there's most of the right atrium located superiorly and inferiorly to it, the right ventricle. They're separated by the coronary sulcus, also called the atrioventricular groove, or AV groove for short. Then, there's the auricle of the left atrium and the left ventricle, which are also separated by the coronary sulcus. The right ventricle and left ventricle are separated by the anterior interventricular sulcus. Moving on, you can actually see parts of the great vessels on an anterior view. So from right to left, there's part of the superior vena cava, which opens in the superior part of the right atrium. Then there's part of the inferior vena cava, which also opens in the right atrium, but the opening can only be seen on a posterior view. Then there's the ascending aorta, which emerges from the left ventricle and then arches toward the back to form the aortic arch. The branches of the aortic arch can also be seen, and from right to left, they are the brachiocephalic trunk, which branches into the right subclavian artery and right common carotid artery, the left common carotid, and the left subclavian artery. Finally, medial to the left auricle, there's the pulmonary trunk, which emerges from the right ventricle and branches into the left and right pulmonary arteries, with the right pulmonary artery going under the aortic arch. Interestingly enough, the superior portion of the proximal left pulmonary artery is connected to the inferior surface of the aortic arch by the ligamentum arteriosum. Even though this fancy-termed element is just a fibrous band now, back during embryological development, it used to connect the aortic arch and the pulmonary trunk as an adaptation of fetal circulation to intrauterine life. Now, on a posterior view, we can see the left atrium and the left auricle, most of the left ventricle, as well as the right atrium and right ventricle. As before, the atria and ventricles are separated by the coronary sulcus, but now the right and left ventricle are separated by the posterior intraventricular sulcus. In the upper portion, above the coronary sulcus, there are the great vessels.
The left and right pulmonary veins, which bring oxygenated blood into the left atrium, and the left and right pulmonary arteries, which emerge from the pulmonary trunk and bring deoxygenated blood to the lungs above them, the aortic arch, and the superior and inferior vena cava.
It's also important to visualize that the most anterior portion of the heart is the right ventricle, and the most posterior part of the heart is the left atrium, which lies directly anterior to the esophagus. And time for a pop quiz. What are the borders of the heart and what structures form them? Very well, let's get back at it. Now let's have a look at each chamber of the heart, starting with the right atrium. This is a right anterolateral view of the heart where we dissected the right atrium in order to see its contents. The right atrium has a smooth, thin-walled posterior part called the sinus venerum, where both superior and inferior vena cava, as well as the coronary sinus, open. Then there's a rough muscular anterior part formed by the pectinate muscles. Externally, the smooth and rough parts of the atrium are separated by a vertical, shallow groove called the sulcus terminalis. Internally, these structures are separated by a vertical ridge called the crista terminalis. Inferiorly, you can also see the right AV orifice, also known as the tricuspid orifice, which is where the blood from the atrium goes into the ventricle. Now, the superior vena cava enters through the superior part of the right atrium, which is roughly at the level of the third costal cartilage. The inferior vena cava opens inferiorly almost parallel to the superior vena cava, roughly at the level of the fifth costal cartilage. Finally, the coronary sinus opens between the tricuspid orifice and the inferior vena cava orifice. Now, the right and left atrium are separated by the intraatrial septum, which has a depression called the oval fossa, or fossa ovalis, which is a remnant of the oval foramen, or foramen ovale, that connected the atria during embryological development. In fetal life, oxygen-rich and nutrient-rich blood travels directly into the left atrium from the right atrium via the foramen ovale to bypass the pulmonary circulation. Let's stay on the right track and move into the right ventricle. Just like before, we're going to look at an anterior view of the heart where we dissected the right ventricle. The right ventricle has an inflow part where blood gets inside the ventricle, and the outflow part through which blood leaves the right ventricle. The inflow part has muscular elevations called the trabecula carne, and the outflow part is formed by an infundibulum called the conus arteriosus, located superiorly and leads to the pulmonary trunk. So far, so good. Now, the right ventricle receives blood from the right atrium through the tricuspid orifice, which is posterior to the body of the sternum at the level of the fourth and fifth intercostal space. The tricuspid orifice is surrounded by a fibrous ring that's part of a fibrous skeleton of the heart, keeping its shape constant. And in order for blood to flow from the right atrium to the right ventricle at exactly the right time during each heartbeat, there's a tricuspid valve attached to the tricuspid orifice. It's called the tricuspid valve because it has three cusps or leaflets that open and close during systole and diastole. An anterior one, a posterior one, and a septal one. The base of each cusp is attached to a fibrous ring, while the free edges of the cusps are attached to tendinous cords called the chordae tendineae. These chordae tendineae anchor the leaflets to the papillary muscles, which are projections of the right ventricle. The anterior papillary muscle is the largest one and arises from the anterior wall of the right ventricle. Its chordae tendineae attach to the anterior and posterior cusps of the valve. Then there's a posterior papillary muscle that arises from the inferior wall of the right ventricle. Its chordae tendineae attach to the posterior and septal cusps. And finally, there's the septal papillary muscle, which arises from the intraventricular septum and chordae tendineae attached to the anterior and septal cusps. This smart and complicated mechanism is mainly meant to block the backflow of blood from the right ventricle to the right atrium during systole, which is when the heart contracts to pump blood out of the ventricles. Okay, we're not done with the right ventricle. Hang in there. The intraventricular septum, or IVS, separates the two ventricles and forms a part of the wall of each ventricle. It's made up of muscular and membranous parts. Now, the muscular part of the IVS is mostly part of the left ventricle, so it's 2 to 3 times thicker than the rest of the right ventricle. The membranous part is a thin membrane that's part of the fibroskeleton of the heart, and it's located superiorly and posteriorly. On the right side of the IVS, the septal cusp of the tricuspid valve attaches to the middle of the membranous part. Finally, in the right ventricle, there's also a muscular bundle that crosses from the inferior part of the IVS to the base of the anterior papillary muscle. This is called the moderator band, or septomarginal trabecula, and it helps the right ventricle contract properly by making the anterior papillary muscle contract at the same time as the other two papillary muscles. So, to put all these structures into perspective, let's briefly talk about blood flow. The right atrium contracts when the right ventricle is empty and relaxed. So blood from the right atrium passes through the tricuspid valve and enters the right ventricle. Finally, blood then leaves the right ventricle through the pulmonary valve, which is located at the level of the third costal cartilage, and enters the pulmonary trunk where blood is sent to the lungs for oxygenation. Okay, now let's pause for a heartbeat and see if you can identify the structures that make up the right atrium and ventricle. Okay, if you didn't get them all right, no worries. We can go left now, starting with the left atrium. The left atrium is slightly thicker than the right atrium, and along with the left auricle and the pectinate muscles within, it forms a large part of the base of the heart. The rest of the left atrium is smooth. The 4 pulmonary veins, namely the left superior, left inferior, right superior, and right inferior pulmonary veins, enter the smooth part of the left atrium posteriorly. Unlike other structures of the heart, the pulmonary veins don't have any valves and blood flows through them and into the left atrium freely. Now, on the intraatrial septum, there's a semilunar depression indicating the floor of the oval fossa, with a surrounding ridge being the valve of the oval fossa, which, as we mentioned before, used to represent a communication between the atria during embryonic development. Finally, inferiorly, there's a left AV orifice, or mitral orifice, through which blood flows from the left atrium into the left ventricle. Finally, let's look at the left ventricle, which forms the apex of the heart. Since the pressure inside the left ventricle is higher, its walls are 2 to 3 times as thick as those of the right ventricle.
The left ventricular walls have more, but finer, trabeculae carnae than the right ventricle.
It also has a smooth-walled, non-muscular part, which is called the aortic vestibule, which leads to the aortic orifice and aortic valve. The aortic valve is located posterior to the left of the sternum at the level of the third intercostal space. The mitral orifice is surrounded by the mitral valve, which is located posterior to the sternum at the level of the fourth costal cartilage. The mitral valve is also referred to as a bicuspid valve, as it only has 2 cusps, anterior and posterior, compared to the 3 cusps of the tricuspid valve. Each of the cusps are attached to the papillary muscles through chordae tendineae, which allow the cusps to resist the high pressure during heart contraction. Now that we're done with the heart chambers, we'll now take a look at the pulmonary trunk and aorta. Blood flows from the right ventricle to the pulmonary trunk via the pulmonary semilunar valve, while blood flows from the left ventricle to the ascending aorta via the aortic semilunar valve. These valves each have 3 cusps, called the semilunar cusps. The pulmonary valve has an anterior, a right, and left cusp, while the aortic valve has a posterior, right, and left cusp. Unlike the tricuspid and mitral valves, the semilunar valves are smaller and don't have chordae tendineae to support them. Instead, during ventricular relaxation, blood is forced backwards into the heart where the cusps catch this reverse blood flow and snap closed like an umbrella caught in the wind. The cusp's edge come together to close the semilunar valves and support each other as their edges meet to prevent backflow. The edge of each cusp is thickened where they meet, forming the lunule, and at the apex of the angulated free edge, they form the nodule. During ventricular contraction, the semilunar valves open as they are pressed towards the walls of the pulmonary trunk and aorta. Superior to each semilunar cusp, the walls of the origins of the pulmonary trunk and the aorta are a bit dilated, forming a sinus where blood gets in to prevent the cusp from sticking to the wall of the vessel when they open, and it also helps them close back up. The sinus formed above the right aortic cusp is the origin of the right coronary artery, and the sinus formed above the left aortic cusp is the origin of the left coronary artery, both of which nourish the heart muscle. During ventricular relaxation, when the semilunar valves are closing, the backflow of blood towards the heart fills these sinuses, and the force of this backflow is what allows the left and right coronary arteries to fill. Now, before going any further, let's take a look at the conducting system of the heart, which consists of nodal tissue that automatically generates and transmits impulses that produce coordinated contractions of the heart muscle, effectively turning the heart into a pump.
One special nodal tissue is a sinoatrial or SA node,
located anterolaterally at the junction of the superior vena cava and right atrium, near the superior end of the sulcus terminalis. The SA node is the pacemaker of the heart, and it establishes the basic heart rhythm. Then, there's the atrioventricular or AV node, which is a smaller bit of nodal tissue located in the posterior-inferior region of the intraatrial septum near the opening of the coronary sinus. The way it goes is that the SA node initiates an impulse that's conducted in the atria, making them contract. The impulse then spreads to the AV node, and afterwards, the AV node spreads the impulse to the ventricles through the AV bundle. Finally, at the junction of the membranous and muscular part of the IVS, the AV bundle spreads into a right and left branch that further stimulates the IVS and then the respective ventricles through smaller branches, called the Purkinje fibers. This way, the ventricles can contract effectively. And that's the basic electrophysiology of how the heart coordinates its contractions so blood can leave the heart and reach every organ in the body.
In addition to the conducting system of the heart is supplied by the cardiac plexus, which is most commonly found on the anterior surface of the bifurcation of the trachea, posterior to the ascending aorta, and the bifurcation of the pulmonary trunk. The cardiac plexus has both sympathetic and parasympathetic fibers, as well as visceral afferent fibers for the reflexive and nociceptive or pain-sensing fibers of the heart.
The fibers of the cardiac plexus run along the coronary vessels and conducting system. Sympathetic innervation is from presynaptic fibers with cell bodies found in the superior 5 to 6 thoracic segments of the spinal cord, and postsynaptic sympathetic fibers with cell bodies in the cervical and superior thoracic paravertebral ganglia of the sympathetic trunks. Postsynaptic fibers travel across cardiopulmonary splanchnic nerves and the cardiac plexus ending in the SA and AV nodes, and they also have connections with the terminations of parasympathetic fibers on the coronary arteries. Sympathetic innervation is needed to increase heart rate, the force of heart contractions, and increase flow through the coronary vessels to support the increased activity. These actions are crucial if you're caught in the wrong neighborhood and are running from a pack of kittens. Parasympathetic innervation, which slows the heart rate and kicks in after you've escaped all those kittens, derives from presynaptic fibers of the vagus nerves. Postsynaptic parasympathetic cell bodies are located in the atrial wall and the intraatrial septum near the SA and AV nodes and along the coronary arteries. Alright, as a quick recap. The heart is a muscular organ located in the mediastinum or thorax between two lungs. The heart has 4 chambers, 2 atria separated by the intraatrial septum, and 2 ventricles separated by the intraventricular septum. The right atrium receives deoxygenated blood from the superior and inferior vena cava, and it sends it to the right ventricle through the tricuspid valve, which has 3 cusps that attach to the papillary muscles via chordae tendineae. Then, the blood passes through the pulmonary semilunar valve and reaches the lungs via the pulmonary trunk and its two main branches, the left and right pulmonary arteries. The left atrium receives oxygenated blood from the four pulmonary veins and then sends it to the left ventricle through the mitral valve, also attached to papillary muscles via chordae tendineae. From the left ventricle, blood is pumped into the aorta through the aortic semilunar valve, reaching the rest of the body. The heart has a conducting system made up of the SA node located anterolaterally at the junction of the superior vena cava and right atrium, the AV node located in the posterior-inferior region of the interatrial septum. Now, on an anterior view, you can see the following structures: the coronary sulcus, the anterior intraventricular sulcus, the superior and inferior vena cava, the ascending aorta, and the pulmonary trunk, as well as the ligamentum arteriosum. On a posterior view, you can see the posterior intraventricular sulcus, left and right pulmonary veins, left and right pulmonary arteries, the aortic arch, and the superior and inferior vena cava. The heart is innervated by sympathetic and parasympathetic nerve fibers from the cardiac plexus, which is most commonly found on the anterior surface of the bifurcation of the trachea.
As we know, the mediastinum is divided into the superior mediastinum and the inferior mediastinum. The superior mediastinum is separated from the inferior mediastinum by the transverse thoracic plane, which is a horizontal plane that extends from the sternal angle anteriorly and the junction of T4 and T5 posteriorly, an important anatomical landmark representing the bifurcation of the trachea and the beginning and end of the arch of the aorta. The inferior mediastinum lies between the transverse thoracic plane superiorly and the diaphragm inferiorly, and is further subdivided by the pericardium into anterior, middle, and posterior parts. So first, let's look at the posterior mediastinum. It is located anterior to the T5 through T12 vertebrae, posterior to the pericardium and diaphragm, inferior to the transverse thoracic plane, and between the parietal pleura of the lungs. The posterior mediastinum contains the thoracic aorta, thoracic duct and lymphatic trunks, posterior mediastinal lymph nodes, azygous and hemiazygous veins, the esophagus, and the esophageal nerve plexus. The thoracic aorta continues the aortic arch, and it begins on the left side of the inferior border of the body of T4, moving downwards in the posterior mediastinum on the left side of T5 through T12 vertebrae. On its way down, the thoracic aorta is close to the median plane and moves the esophagus towards the right. The thoracic aorta lies posterior to the root of the left lung, pericardium, and esophagus, and is surrounded by the thoracic aortic plexus. Anterior to the inferior border of the T12 vertebra, it continues on as the abdominal aorta and enters the abdomen through the aortic hiatus in the diaphragm. The thoracic duct and azygous vein climb on the right side of the thoracic aorta and accompany it through the aortic hiatus. The vascular branches of the thoracic aorta are the esophageal arteries, which supply the esophagus, the bronchial arteries, which supply the lungs, the 9 pairs of posterior intercostal arteries that supply all the intercostal spaces except for the upper 2, and the subcostal arteries which supply the muscles and skin below the 12th rib. Other branches include the superior phrenic arteries, which supply part of the diaphragm, and pericardial branches, which help supply the pericardium. Now, the posterior mediastinum also contains the inferior portion of the esophagus as it continues its course from the superior mediastinum. In the posterior mediastinum, the esophagus passes posterior and to the right of the aortic arch and posterior to the pericardium and left atrium, so it's the main structure posterior to the base of the heart. Then it deviates to the left and passes through the esophageal hiatus in the diaphragm at the level of T10, and at this point it's anterior to the aorta. Remember that the thoracic aorta passes through the diaphragm at the level of T12 and the esophagus passes at level T10. It's also important that the inferior vena cava ascends through the diaphragm at level T8. To remember these anatomical landmarks, think of the phrase, "I ate 10 eggs at 12. The I represents the IVC at 8, the eggs represent the esophagus at T10, and the at 12 is aorta at T12. Also remember, the phrenic nerve pierces level T8 along with the IVC, the vagus nerve pierces T10 along with the esophagus, and the thoracic duct pierces at level T12 along with the aorta. Now, the esophagus may have 3 anatomic impressions or constrictions in the posterior mediastinum caused by 3 structures it meets on its way down: the aortic arch, the left main bronchus, and the diaphragm. These narrowings can be seen in oblique chest radiographs if a person were to undergo a barium swallow study. Also know that there is another potential constriction of the proximal esophagus prior to it entering the posterior mediastinum at the level of the cricoid cartilage. Remember that the surface esophagus is covered by the esophageal plexus, which is derived from the left and right vagus nerves as they descend through the superior and posterior mediastinum. The esophageal plexus goes on to form the anterior and posterior vagal trunk found on the inferior esophagus just before the esophagus passes through the diaphragm. These vagal trunks pass through the diaphragm with the esophagus and go on to innervate a large part of the GI tract. Let's now tackle the veins of the azygous venous system. It's located on each side of the vertebral column, and it drains the back, the thoracoabdominal walls, and the mediastinal viscera. Now, this system contains the azygous vein, the hemiazygous vein, and accessory hemiazygous veins. So, the azygous vein travels proximally up the posterior mediastinum and forms a collateral pathway from the posterior aspect of the inferior vena cava at the level of the renal veins. In the posterior mediastinum, the azygous vein passes close to the right side of the bodies of the inferior 8 thoracic vertebrae, posterior to the root of the right lung. Then it arches over the superior aspect of the root of the right lung to join the superior vena cava. The azygous vein also receives the mediastinal, esophageal, and bronchial veins. Now, the hemiazygous vein originates on the left side of the vertebral column, posterior to the thoracic aorta as far as the T9 vertebra. At this point, it crosses to the right, posterior to the aorta, thoracic duct, and esophagus, and joins the azygous vein. It receives the inferior 3 posterior intercostal veins, the inferior esophageal veins, and many small mediastinal veins. The accessory hemiazygous vein originates at the medial end of the 4th or 5th intercostal space and goes down on the left side of the vertebral column from T5 through T8. It receives blood from veins in the 4th through 8th intercostal spaces and sometimes even from left bronchial veins. It crosses over the T7 or T8 vertebra, posterior to the thoracic aorta and thoracic duct, at which point it joins the azygous vein. Okay. Let's now talk about the thoracic duct, which is the largest lymphatic channel in the body and conveys most of the lymph in the body to the venous system, specifically all lymph except from the right superior quadrant of the body. In the posterior mediastinum, it lies on the anterior part of the bodies of T12 to T5. The thoracic duct originates from the cisterna chyli in the abdomen and enters the mediastinum through the aortic hiatus in the diaphragm at the level of T12. It then goes up in the posterior mediastinum among the thoracic aorta on its left, the azygous vein on its right, the esophagus anteriorly, and the vertebral bodies posteriorly. At the level of T4, T5, or T6, the thoracic duct crosses to the left, becoming posterior to the esophagus, and enters the superior mediastinum. The thoracic duct typically empties into the venous system close to the joining of the left internal jugular and subclavian veins at a point called the left venous angle, or origin of the brachiocephalic vein. Now, the lymph nodes of the posterior mediastinum lie posterior to the pericardium, close to the esophagus and thoracic aorta. Some nodes lie posterior to the inferior part of the esophagus, but most of them lie anterior and lateral to it. The posterior mediastinal lymph nodes receive lymph from the esophagus, the posterior aspect of the pericardium and diaphragm, and the middle posterior intercostal spaces. Lymph eventually collects into the thoracic duct from these nodes on their way to the left venous angle, or depending on location, lymph may also drain into the right lymphatic duct to drain into the right venous angle. Next up, there are the nerves of the posterior mediastinum, namely the thoracic sympathetic trunks and their ganglia, which form a major portion of the autonomic nervous system. In the superior part of the thorax, the thoracic trunks lie against the heads of the ribs. In the mid-thorax, they lie against the costovertebral joints, and in the inferior part of the thorax, they lie on the sides of the vertebral bodies. The sympathetic trunk has one sympathetic ganglion for each thoracic vertebral level, and each ganglion is connected to their respective intercostal nerves via two rami communicantes. These two rami are the afferent white rami and the efferent gray rami. White rami carry preganglionic sympathetic fibers from the spinal nerves to the sympathetic ganglia, while gray rami carry postganglionic sympathetic fibers from the sympathetic ganglia to the spinal nerves. Preganglionic sympathetic fibers only originate from the T1 to L2 spinal levels, so there are no white rami above T1 or below L2 or L3, so sympathetic fibers ascend or descend the sympathetic trunk in order to provide sympathetic innervation from our heads down to our toes. This is possible because the thoracic sympathetic trunk is continuous with the cervical trunk above and lumbar sympathetic trunk below, both of which don't have white rami communicantes. Now, distally, the sympathetic trunks give rise to the lower thoracic splanchnic nerves, specifically the greater from T5 to T9, lesser from T10 and T11, and least splanchnic nerves coming from T12, which descend into the abdomen and supply the abdominal viscera. They have presynaptic fibers from the 5th through the 12th sympathetic ganglia that pass through the diaphragm and synapse in prevertebral ganglia in the abdomen, which go on to supply abdominal viscera below the diaphragm. Okay, let's take a quick break and see if you can remember what are the limits of the posterior mediastinum and the structures it contains. Next, let's focus on the middle mediastinum, which includes the pericardium, heart, and roots of its great vessels, such as the ascending aorta, pulmonary trunk, and superior vena cava. Let's take a look at the pericardium, which is a fibroserous membrane that covers the heart and the beginning of its great vessels. It's a closed sac with two layers, an external one called the fibrous pericardium and an internal one called the serous pericardium. The external layer is continuous superiorly with the tunica adventitia of the great vessels and the pretracheal layer of the deep cervical fascia. It's attached anteriorly to the posterior surface of the sternum through the sternopericardial ligaments, and it is continuous inferiorly with the central tendon of the diaphragm. The fibrous pericardium is lined with a serous membrane called the parietal layer of the serous pericardium. This layer is reflected onto the heart and its great vessels as the visceral layer of the serous pericardium. Now, the visceral layer of the serous pericardium forms the epicardium, which is the external layer of the heart. It extends onto the beginning of the great vessels and becomes continuous with the parietal layer of the serous pericardium. Within the pericardial cavity, which is a potential space formed between the parietal and visceral pericardial layers, the transverse pericardial sinus is a running passage between the vessels that leave the heart, specifically the aorta and pulmonary trunk, and the vessels that enter the heart, specifically the superior vena cava, the inferior vena cava, and pulmonary veins. The oblique pericardial sinus is the reflection of the serous pericardium around the vessels that enter the heart, bounded laterally by the IVC and pulmonary veins, forming a pouch that can be accessed inferiorly. The arterial supply of the pericardium comes from the pericardiophrenic artery, which is a branch of the internal thoracic artery. This branch usually accompanies or parallels the phrenic nerve to the diaphragm. Other arteries include the musculophrenic artery, which is a terminal branch of the internal thoracic artery, the bronchial, esophageal, and superior phrenic arteries, which are branches of the thoracic aorta, and finally the coronary arteries, which are the first branches of the aorta. The venous drainage of the pericardium is handled by pericardiophrenic veins, which are tributaries of the brachiocephalic veins and various tributaries of the azygous venous system. The nerve supply of the pericardium mainly comes from the phrenic nerves, which are primary sources of sensory fibers and pain sensations, which are referred to the skin on the C3 through C5 dermatomes of the ipsilateral supraclavicular region. Other fibers come from the vagus nerves and the sympathetic trunks. Can you remember the course of the phrenic nerves? Correct. Anterior to the lung hilum and over the pericardium towards the diaphragm. How about the vagus nerve? Correct. Behind the lung hilum to the esophagus. Finally, the anterior mediastinum, which is the smallest subdivision of the mediastinum, lies between the body of the sternum and the transversus thoracis muscles anteriorly and the pericardium posteriorly. The anterior mediastinum consists of loose connective tissue, fat, lymphatic vessels, few lymph nodes, and branches of the internal thoracic vessels. In children, it also contains the inferior part of the thymus. Alright, as a quick recap, the mediastinum is divided into the superior mediastinum and an inferior mediastinum, which are separated from each other by the transverse thoracic plane. The inferior mediastinum is bounded inferiorly by the diaphragm and is further subdivided into anterior, middle, and posterior mediastinum. The posterior mediastinum is located anterior to T5 through T12 vertebrae, posterior to the pericardium and diaphragm, inferior to the transverse thoracic plane, and between the parietal pleura of the lungs. It contains the following structures: thoracic aorta, thoracic duct and lymphatic trunks, posterior mediastinal lymph nodes, azygous and hemiazygous veins, esophagus and the esophageal nerve plexus. The middle mediastinum includes the pericardium, heart, and roots of its great vessels, such as the ascending aorta, pulmonary trunk, and superior vena cava. The anterior mediastinum lies between the body of the sternum and the transversus thoracis muscles anteriorly and the pericardium posteriorly. The anterior mediastinum consists of loose connective tissue, fat, lymphatic vessels, few lymph nodes, and branches of the internal thoracic vessels.
The mediastinum is the central compartment of the thoracic cavity, and it lies between the two pulmonary cavities. It's covered on each side by the mediastinal pleura and contains all thoracic viscera and structures minus the lungs. The mediastinum is divided into 4 parts, one of which is superior, and 3 that are inferior. The superior part is bounded superiorly by the thoracic aperture, and extends inferiorly to the transverse thoracic plane, which is a horizontal plane that extends from the sternal angle anteriorly and the junction of T4 and T5 posteriorly. The transverse thoracic plane separates the superior mediastinum from the inferior mediastinum and is also an important anatomical landmark representing the bifurcation of the trachea and the beginning and end of the arch of the aorta. The inferior mediastinum lies between the transverse thoracic plane superiorly and the diaphragm inferiorly. It's further subdivided by the pericardium into anterior, middle, and posterior parts, with the pericardium and its contents being in the middle part. So, in this video, let's focus on the superior mediastinum. From anterior to posterior, it contains the following structures: the thymus, the great vessels, the inferior continuation of the trachea, the inferior continuation of the esophagus, and the thoracic duct and lymphatic trunks. Now, let's take a closer look at some of these structures one by one. So, the thymus is located in the inferior part of the neck and in the anterior part of the superior mediastinum. It is a glandular structure, and it lies posterior to the manubrium and extends into the anterior mediastinum. The thymus is a primary lymphoid organ that plays a huge role in helping our immune cells develop before puberty. After puberty, however, it undergoes gradual involution and is mostly replaced by fat. Next up, there are great vessels. First, we have the veins, which include the brachiocephalic veins and the superior vena cava, or SVC, as well as the arteries, which include the arch of the aorta and its major branches, the brachiocephalic trunk, left common carotid artery, and left subclavian artery. Let's take a look at this picture and identify the left and right brachiocephalic veins, which form posterior to the sternoclavicular joints by the joining of the internal jugular and subclavian veins. Then, the brachiocephalic veins join to form the SVC at the level of the inferior border of the first right costal cartilage, with the left brachiocephalic vein being longer than the right one, since it has to travel farther to drain to the right side of the heart. Now, the SVC then passes inferiorly and ends at the level of the third costal cartilage, at which point it enters the right atrium. The SVC lies on the right side of the superior mediastinum, anterolateral to the trachea and posterolateral to the ascending aorta. The SVC is anterior to the root of the right lung, and the azygous vein drains into its posterior surface. Next up, there's the aortic arch, which continues the ascending aorta and begins at the level of the sternal angle, posterior to the second right sternocostal joint. As you can see in this picture, it arches superiorly, posteriorly, and to the left, and then inferiorly. The arch goes up anterior to the right pulmonary artery and the bifurcation of the trachea. It reaches its apex as it passes over the root of the left lung, at the left side of the trachea and esophagus. The arch descends posterior to the left root of the lung beside T4 and ends by becoming the thoracic or descending aorta posterior to the second left sternocostal joint. Now let's take a really quick break and see, can you recall the plane that the beginning and end of the arch of the aorta is divided by? That's right, we're talking about the transverse thoracic plane. Now, the branches of the aortic arch are the brachiocephalic trunk, left common carotid artery, and left subclavian artery. The brachiocephalic trunk is the first and largest branch of the aorta. It arises posterior to the manubrium, at which point it's anterior to the trachea and posterior to the left brachiocephalic vein. Then, it ascends superiorly and laterally to reach the side of the trachea and is found posterior to the right sternocostal joint, where it divides into the right common carotid and right subclavian artery. The left common carotid artery is the second branch of the aortic arch. It originates posterior to the manubrium, but slightly posterior and to the left of the brachiocephalic trunk. It ascends anterior to the left subclavian artery and enters the neck posterior to the left sternocostal joint. The left subclavian artery is the third branch of the aortic arch and has its origin in the posterior part of the arch, posterior to the left common carotid artery. It ascends through the superior mediastinum lateral to the left common carotid artery and enters the root of the neck by passing posterior to the left sternocostal joint. One last important structure to mention in the superior mediastinum is the ligamentum arteriosum. The ligamentum arteriosum is a fibrous band, which is an embryological remnant of the ductus arteriosus from birth, which acted as a shunt for blood to travel from the pulmonary trunk to the aortic arch in order to bypass the fetal lungs, which weren't functional in utero. The ligamentum arteriosum remains and passes from the superior portion of the proximal left pulmonary artery to the inferior surface of the aortic arch. Before moving forward, Let's see if you can remember what the superior mediastinum contains from anterior to posterior. Alright, so we're going to assume that you got that exactly right, so we can now move on to the nerves. As you can surely remember, there is a pair of vagus nerves which carry sensory, motor, and autonomic information to the mediastinum. They exit the cranium and go down through the neck, posterior and lateral to the common carotid arteries. They then enter the superior mediastinum, posterior to the left and right sternocostal joint and brachiocephalic vein. The right vagus nerve enters the thorax anterior to the right subclavian artery, at which point it gives rise to the right recurrent laryngeal nerve. This nerve goes around the right subclavian artery and ascends between the trachea and esophagus to supply the larynx. Back to the right vagus nerve. It runs postero-inferiorly through the superior mediastinum on the right side of the trachea, then passes posterior to the right brachiocephalic vein, SVC, and root of the right lung. At this point, it divides into many branches which contribute to the right pulmonary plexus. The right vagus nerve typically leaves this plexus as a single nerve and passes to the esophagus, where it gives many branches to contribute to the esophageal plexus. The right vagus nerve also gives rise to nerves that contribute to the cardiac plexus. The left vagus nerve descends in the neck posterior to the left common carotid artery, then enters the mediastinum between the left common carotid artery and left subclavian artery. When the left vagus nerve reaches the inferior border of the arch of the aorta, it curves medially and gives rise to the left recurrent laryngeal nerve. This nerve passes inferior to the aortic arch, lateral to the ligamentum arteriosum, which we talked about earlier, and climbs to the larynx in the groove between the trachea and the esophagus. The left vagus nerve passes posterior to the root of the left lung, where it gives many branches to contribute to the left pulmonary plexus. Then, the left vagus nerve leaves this plexus as a single trunk and goes to the esophagus, where it contributes to the esophageal plexus. Both vagus nerves eventually pierce the diaphragm at the T10 level along with the esophagus to provide further innervation to the abdomen. Next up, there's the paired phrenic nerves, which supply the diaphragm with both motor and sensory fibers, and they also supply the pericardium and mediastinal pleura with just sensory fibers. Quite the overachievers, I'd say. Each phrenic nerve reaches the superior mediastinum between the subclavian artery and the origin of the brachiocephalic vein. Unlike the vagus nerves, the phrenic nerves pass anterior to the root of the lungs. The right phrenic nerve passes along the right side of the right brachiocephalic vein, SVC, and the pericardium over the right atrium. It also passes anterior to the root of the right lung and descends on the right side of the inferior vena cava to the diaphragm. The left phrenic nerve descends between the left subclavian and left common carotid arteries, then crosses the aortic arch anterior to the left vagus nerve. Now, the left phrenic nerve descends anterior to the root of the left lung and runs along the fibrous pericardium, superficial to the left atrium and ventricle of the heart, and it pierces the diaphragm at the level of T8 to the left of the pericardium, providing innervation to it. The phrenic nerve is a mixed sensory and motor nerve, with contributions from spinal levels C3, C4, and C5. If the phrenic nerve becomes irritated where it innervates the diaphragm or parietal pleura, it can lead to something called referred pain to the dermatomes, supplied by the same spinal region the phrenic nerve originates from. So in this case, phrenic nerve irritation will cause a referred pain to the dermatomes of C3, C4, and C5, and this will manifest as root of the neck pain, which is C3 and C4, or shoulder tip pain, which is C5. This is why diaphragmatic or lung irritation can cause people to have shoulder tip pain, and this is a classic example to describe referred pain, similar to how heart attacks can cause a shooting pain in the neck or arm. Okay, now let's switch gears and look at the trachea, which descends anterior to the esophagus and enters the superior mediastinum. Looking at it in the median plane, it's positioned a bit to the right. The posterior surface of the trachea, which borders the esophagus, is flat, and the trachea ends and divides into the right and left main bronchi at the level of the sternal angle marked by T4 and T5 junction. And finally, the esophagus is a fibromuscular tube that extends from the pharynx to the stomach. It enters the superior mediastinum between the trachea and vertebral column, lying anterior to the bodies of T1 through T4. Typically, the esophagus is flattened anteroposteriorly. To the left side of the esophagus, there's the thoracic duct, which is also medial or deep to the aortic arch. Inferior to the aortic arch, the esophagus passes in the diaphragm through the esophageal hiatus. All right, as a quick recap, the mediastinum is divided into the superior mediastinum and an inferior mediastinum, where the inferior mediastinum is further subdivided into the anterior, middle, and posterior mediastinum. The superior mediastinum lies between the thoracic aperture superiorly and the transverse thoracic plane inferiorly. From anterior to posterior, the superior mediastinum contains the thymus, the great vessels, the inferior continuation of the trachea, the inferior continuation of the esophagus, and lymphatic trunks.